So what is basically a regenerative medicine?
Orthopedics does not mean surgery. We slowly start degenerating. But how do you regenerate? Our body produces regenerative material that is good enough to regenerate our own body. And we're able to inject them into the desired areas. The stem cells can actually help regenerate that area.
You know, a person is above 70 or something. Is there age or criteria?
So even though the person is 70, 80, 90, he has enough cells. The difference is it's not the age, how bad the condition is.
We are seeing different types of injuries with the general population as well that we have typically seen only in athletes few years ago.
They don't heal well. So what we do, we go in the bone as well, called a subchondral. It's called interosseous.
Limitations and a proper rehab is something which is really required even after a PRP.
If somebody comes with a meniscal tear, and we do stem cells on there. So the rehab is a little bit longer. But if they don't work out, they get deconditioned. The rehab is the most important part post-procedure. And we don't have muscle strength, they're going to have the same problem later.
If there is a surgery done, let's say an ACL reconstruction or anything of that sort is already done, even the surgery hasn't helped a lot, does it make sense to do a regenerative after it?
You know, ACL surgery is a good thing, but there's a high chance of re-tear. Most of the partial ACL tears, we heal them with stem cells. They don't need surgery at all.
It all depends on the nature of an injury and the assessments, and that's where assessments become extremely important for us.
When there is no cutting involved, there is no downtime of healing the tissues. So you're not disturbing the architecture, you're actually enhancing the architecture.
When we're talking about athletes, what is always on their mind is their short career span. How quickly they can get back to their sports. The regenerative medicine is extremely helpful for both athletic as well as the general population.
Hi, I'm Surbhi here. I'm the senior physiotherapist from Stansel. And today on this podcast, we have Dr. Venkatesh. Welcome. So we also have Anand here, who is a strength and conditioning coach. Welcome. Hi, good evening, doctor. How are you doing?
Good evening.
Nice to see you here.
Thank you.
Okay.
Nice to see you. Yeah. Good evening. Hi.
Yeah.
Okay, so let's begin the discussion. There's something which I want to ask you is, so what is basically a regenerative medicine and how do we actually, why is it becoming very important these days?
In simple terms, like the name itself tells, it's regenerative medicine. So we're used to our conditions being degenerative, right? As we use it, or injuries, whatever the reason may be, we slowly start degenerating. So the process that can help the degeneration, reverse that thing, is more regenerative medicine. So our focus is mainly orthopedic regenerative medicine, so musculoskeletal.
Okay.
So this regenerative orthopedics, it's called, because we're familiar with what? Surgical orthopedics. Everybody knows surgical orthopedics, but orthopedics does not mean surgery. Most of the orthopedics is non-surgical. So anything that requires surgery is surgical orthopedics, but they still need to get better. The orthopedic conditions still need to get better, right? But there are ways we can do better by using the regenerative medicine. So in one word, I would say any orthopedics that is not surgical, that's interventionally, we can make it into a regenerative orthopedics. So that's the basic, simple definition of regenerative medicine. But for that thing, we use certain methodology. But how do you regenerate? I mean, you can't just regenerate without anything, right? There should be something. So nowadays, we're able to figure out there are a few things in your own body. So our body produces regenerative material, biological material, that is good enough to regenerate our own body. So our body produces our own. So we're able to extract them nowadays, and we're able to inject them into the desired areas with the technology. So all these things have developed in the last 15, 20, 25 years. So we're able to make this into a special field and treat these injuries non-surgically using your own biologics.
Okay, that's great. So what all are the methods or which are available right now in the market as such, if we talk about, or options available as a regenerative therapy that you can
Sure.
throw some light on that?
Yeah. So the most common thing is PRP. Everybody must a lot of people probably used it or they probably know about it. So it's called plasma-rich platelets. So that comes from one's blood So our blood produces growth factors, and so platelets is a good source of growth factors. So that's one of the sources. And the other thing is the bone marrow. So our bone marrow produces what are called mesenchymal stem cells, adult stem cells. And these are good for regeneration potential. And we also can get some growth factors from yours. There's certain other products called exosomes, like autologous conditioned serums. There are multiple things. But the main things when you say like a regenerative material nowadays that's used in orthopedic conditions, musculoskeletal, it's usually stem cells, platelets.
I've also came across a term called BMAP or, ASP. How is that different from PRP, and like how is it?
Yeah, so there's a big difference. The PRP is what you hear is called the plasma-rich platelets. The source of PRP is your blood. It's coming from your blood. It's used for conditions like tendinitis, tendinosis, inflammation. So the platelets go in and create the healing response there. But imagine if the injury is bigger. Say like it's not tendinosis anymore. There's a tear. There's a partial tear, shoulder, labrum, meniscal tear. So PRP is not strong enough. The growth factors are not strong enough. So then we have to go with the BMAC, what you mentioned. BMAC means bone marrow aspirate concentrate. So it comes from your own bone marrow. So that gives good, rich cells, like which are stem cells as well, called adult stem cells. So BMAC contains those things. So by using a BMAC in an injury, even arthritis or tears or any of those degenerative conditions, the response is much, much higher, and it's robust because the stem cells can actually help regenerate that area. So the difference between the PRPs and stem cells is use the PRP for minor tendinitis type situation, but whenever there is any degeneration, BMAC gives you the best outcome.
Better option. Is there any way to say that in a conditions where a person is above 70 or something, is there age a criteria where you say that PRP will work or BMAC will work, or it's more of a clinical?
Not really. That's I would say that's like overly used narrative saying that you're too old, you don't have enough cells. That's not true. So we don't, because until we die, our body makes these things. So we stop making it when we die. So we have enough in our own body to heal our own body. So even though the person is 70, 80, 90, he has enough cells. We're talking almost 1 trillion cells turnover every day. Like, when I'm born, I have different cells, and by evening time, it's totally different. So there is so much of regenerative capacity. So does not matter what the age is. The difference is it's not the age, how bad the condition is. Say like if somebody comes with a severely degenerated joint, knee joint, the patient could be only 40 years old. And there's an 80-year-old gentleman comes in with minor degeneration. He is a better candidate. So age is not a factor. It's like how bad the condition is, what stage you're in. That's what dictates whether you're a good candidate for this or not.
Usually the extent of injury or even the structures, I feel, can be one of the call that we have to take, or which should be used. Like if it's a tendon or if it's a cartilage or something like that, I feel that's also one of the important criteria to decide whether you want to go for a PRP or a BMAP.
No, absolutely, because certain structures, as you said, like they heal easy, right? You break a bone, you heal easy because bones have stem cells all over them. But you tear a cartilage, it does not heal because there's not enough inherent blood supply. So those are stubborn to heal. So those are the places you may want to go stem cells. But if it's a tendon, just a tendinitis, there's not much tear, you can go PRP in those scenarios. So it's the degree of the problem and the kind of tissue as well.
That's very interesting actually when you say that bone will heal faster than the cartilage. I just wanted to ask here if there is a repetitive injury, like a chronic overload injury, which would have caused a structural damage to a bone. Will the nature of injury will also matter in terms of what kind of treatment that will be used? Because we are seeing different types of injuries with the general population as well that we have typically seen only in athletes few years ago. So how does that
So yeah, when there is stress overload, as you're saying, like repetitive injuries, stress fractures, and those, even though they're bones, sometimes they don't heal, right? But there are certain bones in the body, like you take the scaphoid, say the talus. There's certain bones that are notorious for non-healing. So we expect, like, bone should have a lot of stem cells; it should heal. There's certain areas that are not as vascular. There are a few bones like that. When a patient has that problem, doesn't matter what age, they don't heal well. So we got to go help even that condition. So when there is a bone changes, for example, if the bone is getting damaged, we take a knee arthritis, for example. So cartilage is the problem, right? Most of the time you lose the cartilage, you lose the meniscus, and the bone starts getting. But you also develop subchondral changes. The bony changes. As you go to stage 2 and beyond 3, you see the bones are getting. But where do the cartilage gets the blood supply? From the bone. So if we try to repair only the cartilage, they're not going to get better. So what we do, we go in the bone as well, called a subchondral.
Right.
It's called interosseous.
Yeah.
So nowadays we see tremendous results by going interosseous in those, as you said, bone-on-bone stress-related situations. It's recognizing the problem. So does he have any bone changes? Or is it only soft tissue? If you have bone changes, we have to address that area as well. Yeah. So it's more customized basing on what the patient is going through.
Very interesting. Yeah.
Have you come across any of the cases like stubborn shin splints which getting solved because of this, or any of that sort?
Yeah, absolutely. I mean, like, it's supposed to be tendonitis, but there are a lot of bone changes that you see, and stress fractures. You see a lot of them. So, I mean, number one is diagnosing properly. If you don't diagnose and you put that patient through a lot of vigorous work, the stress fracture is going to be an occult fracture, which you don't want to be. So, and experts like you, I think you do a good job finding out that thing. Once we know, then you modify the activity levels. And if it's, as I said, like if there's a damage, if there's a tear in the muscle, then you have to go biological, heal the tear. Then you can put them through a lot of workouts. Then they can be efficiently back on track. If you don't recognize it, then the injury compounds. It gets worse and worse.
Great.
So the first thing what we do as a physio is whenever a patient walks in with any of the aches and pains, we go and look into depth to understand what is the structure involved, what is actually the source of pain. We also try to get a lot of information about using our tech, that how, to what extent it is actually getting involved. And then once we know the extent and source of injury, there are certain options, or sometimes we even try out a rehab process. Let's say where we feel that the structure involved can actually go for a healing without a regenerative medicine. We also try to work on the rehab part of it. So accordingly, we take a call, and then we refer it to a sports med doctor or anything. Is there something that you want to add on this, on like when is the right time?
That's the basic. What you said is, when a patient comes to you, and obviously taking the history, a thorough physical examination, and there should be some degree of certainty, like, okay, what's going on, what's not going on. Sometimes when you're not sure, obviously, you'll be getting some imaging studies or other things, or a sports med evaluation, right? So, but not everybody needs a doctor, because you can probably look into a patient and see the imbalances, muscle atrophies. So you can start working on those things, and obviously with the proper training, and you're not going to put somebody through a lot of stress without giving a proper loading. So, but whenever there are red flags, say like, you'll be able to see that, okay, there's something wrong, he's not responding, or there is an injury pattern. There's a red flag, he's getting inflammation, or he's a little lax, whatever. There's an injury pattern. You suspect a structural issue. That's when it's appropriate to refer to a doctor like us. So then we can evaluate through MRIs or ultrasounds, multiple scanning methods. So once we diagnose it, if somebody needs a treatment, then obviously, as we spoke about, we can give any of these biological treatments. If somebody doesn't need a treatment and it's not as bad of an injury, then you can be aggressive. Because before knowing that, we don't know whether you want to be, somebody has a frozen shoulder, we don't know if you want to be too aggressive. What if he has a tear? Yeah, you don't want to make it bigger. So once you have a diagnosis now you can be aggressive. Hey, it's just frozen, nothing is there. So as a teamwork, it's like you seeing, and if there is a suspicion, then us seeing, and we see something, we'll let you know. So it's kind of, it has to be hand in hand so that the patient gets the best results that way. And we're not ignoring, or at least not making anything worse, and diagnosing it properly.
Like a multidisciplinary approach is something which actually benefits a patient a lot in that. And I also feel that the conversation, communication should be very transparent, and we usually then we give them options, like these are the things which you can go ahead with and try out. That
Absolutely,
rehab can work, or you want to go with regenerative medicine or something like that.
No, absolutely, and I'm sure like you're educating in the process, right? Like what to look for, what not to look for, because the normal tendency is like, well, I mean, I would say like not everybody. Somebody says like, whenever I have pain, I will see somebody. Kind of pain is not an indicator of an injury or deconditioning or so. So that education, educating like, hey, you don't wait for the pain to come back, but if there's a deficiency, we look some imbalance in you. There's something we need to do. So while educating the patient, they'll be ready when they really have a symptom or something. They will seek our attention much quicker. So that's very important.
So now once we have taken a decision, like let's say my client has to go for a regenerative medicine, let it be a PRP or a BMAC or a ASP. So we do, as a physios and SNC coaches, when we come and work together or towards a client, we follow a certain, a protocol as such, which can be very customizable protocol. But let's say a PRP is done. We usually wait for like a 72-hour after that to start loading it, and then rehab begins after 72 hours, and then we go around for like a 3 to 4 weeks more with physio side, and then we actually look into further more details, like again the assessments will be done in the process, also understanding the contributing factors to the structure which is getting loaded, and then we start to work on that. And how do you feel about the process itself? Also, I would like to know more about, is there any difference that we should look into when it comes to like a PRP, ASP and BMAC? How about that?
No, that's refreshing to hear, because you guys are using a protocol that's helping, not like overloading quickly. Because the lack of knowledge is that can really harm the patient if you don't do the proper loading mechanisms. So for example, if somebody gets a PRP or stem cells, that means obviously there's a problem, right? Some people even get proactively. So some of our athletes, they just get proactively, they get some off season, they come in and they have a little issue, I would just want to do it. So if there is an acute injury, obviously the downtime is much longer. If somebody comes with a meniscal tear, and we do stem cells on them, so the rehab is a little bit longer, a bit slower, because you have to give enough time for the biological functions to happen. So 1 week we tell most of these patients not to work out at all. Right? So because you want to get the inflammation calmed down, so normal walking has to be. Then you guys will take over. You take over, and obviously the protocols you mentioned, like you're going to slowly load that person. So week by week, typically most of our procedures are considered outpatient, ambulatory procedures. So there is no like months and months of downtime, bed rest, none of those things. So they're walking in, walking out. Only thing they're not doing is jumping, running, sports like that. But that's where you will be working them towards that. So after the first week, you start working with them, and week by week you bump it up. It's not like whether the patient is able to do it. We just don't want that escalation too quickly, because either PRP or stem cells, the biological action to see clinical improvements on an average is a month. So they're not going to be, if somebody comes with inflammation and pain, they're not going to be better next week. But if they don't work out,
Yes.
they get deconditioned. So we need them to work out, maintain it, but not fully load it. So we tell them to escalate it by a month, your full speed, like how you are. And second month, you just go to sports, whatever you guys can work him up.
Yes.
So that's how they do it. If it's a chronic injury and they're coming for just a little touch up, much quicker. I mean, there's not much downtime at all.
Yes. What I would also, tell the people who are hearing this podcast, like the PRP and Rehab is not like a magic. It will have its own, limitations, and a proper rehab is something which is really required even after a PRP and any other kind of regenerative medicine is done.
Actually, that's the most important point, because people think like, oh, I get the stem cells, I get the PRP, I'm good. No.
Yes.
Because why are they even coming to us? Either they have an injury or they have a chronic problem. That means by the time we see them, they're already deconditioned. That means either they're limping or they're not using, they're not in their full physical fitness, right? The most important thing is, we inject, we take care of them. But if they don't correct their problems, so the rehab is the most important part post-procedure. Obviously pre-procedure, but pre-procedure, they're in pain. They cannot do the rehab effectively. Post-procedure, they're getting better. So the most important is whatever imbalance you have, whatever atrophy you have, whatever limited range of motion you have, you need to correct that thing. If you don't correct and you walk the same way and you don't have muscle strength, they're going to have the same problem later. So we tell all our patients, very, very important, find a qualified and very knowledgeable physical therapist or trainers, because that's the bigger part of their recovery. Because once our procedure is over, they spend a lot of time with the specialists like you, and what you do matters the most, whether they're going to be 90% or 100%. So it is very, very important.
Yes.
If not before, at least after the procedure.
But like I also want to throw some light on a prehab part of it, because then generally what we have seen, let's say there's a case of cartilage or damage or a knee at the knee case or something like that. So there, what I feel, prehab is very, very important when it comes to strengthening your posterior chain or strengthening your anti-gravity muscles there, because the without actually loading them. So, exercising in probably a little non-weight bearing, all of that, just to build or actually, trigger or just wake those muscles up for what's coming up next is what I feel is also one of the most important thing as a prehab, when we say that actually getting more ready for what's going to come.
I think it is essential for return to performance as well, right? Because muscle imbalance and atrophy is one factor of it, which actually has resulted into that, especially in the case of chronic injuries. These are the factors which are building up towards making that injury. But the original cause could be in the mechanics, right? So, for example, the knee cartilage or patellar tendonitis in runners could be due to the poor running mechanics, and that has to be taken care of in the post treatment rehab part. So that's essential as well in that sense.
No, absolutely. And not only that thing, so say like the prehab part, like say like if they have an injury, whatever, even prehab, you guys recognize it. Okay, there's some mechanical issues right there. But if they come stronger to us, then there's not much downtime.
Right.
And they go back to you and they quickly. Imagine if somebody like is in an injury, for example, they have not come to you guys and they just come for the treatment and they've never done exercises. And how hard is for us them to motivate to learn something. So, but again, a lot of people don't recognize it until they start feeling the pain, and that's when they want to see the doctor. But I'm talking about, Bangalore has a lot of health-minded, wellness-minded. So always like moving, keeping themselves fit, making sure, working with the physio to see, hey, do I have anything going on? Do I have any red flags that I have problem down the lane? So that's a very good way of proactively working with you guys. And then if there's an injury, obviously we're always there to take care of that.
So, working on the contributing factors is something which is really important before actually looking at the structure, which is like the involved,
exactly.
especially in the prehab. This is also
Yeah. See, there's a reason that happened.
Yes.
Why would somebody tear something? There's a reason, right?
Yes.
Either his VMO is weak or injury, obviously sometimes, but the loading could be different. So we have to recognize that thing and work on those corrective exercises. That's the goal. You have to correct those exercises. So not everybody's rehab is the same. Not everybody's body is the same. So finding out what the problem is, that's the key. And then you're giving that guy a great life later. Otherwise, he may be going with injuries and having multiple medical problems down the lane. Yeah.
Also, I would like to know if there is a surgery done, let's say an ACL reconstruction or anything of that sort is already done. Are there any cases we have seen that even the surgery hasn't helped a lot, or the pain is still there, or because of any factors that can be? Does it make sense to do a regenerative after it, or is there any way to look into it, like a post-surgical cases?
So nowadays, most of the partial ACL tears, we heal them with stem cells. They don't need surgery at all. The only time they may need a surgery is when they have laxity, giveaway with a complete tear. I mean, we're talking all the fibers are gone. And there's laxity. Even sometimes all the fibers are gone. If they have good muscle strength, they can really function normally unless they're pro athletes. But partial tears, even pro athletes, we heal really good with the stem cells, basically. So that's one case, right? We also have patients that have post ACL. So ACL surgery is a good thing, but there's a high chance of re-tear. You see in athletes, almost 50% of them re-tear, because with the ACL graft, you're losing your natural mechanics. It's a single braid. It's not a double braided graft. Graft is single and your natural ACL is double braided. So there is mechanical changes will be there. So we see a lot of people post ACL surgeries that are active in their life. A lot of them come with some graft tears as well. And that's one thing. The other thing is they also put unnecessary pressure on the medial compartment, meniscal tears. So they're more prone to arthritic symptoms as they go on. So recognizing that and correcting, as I said, and if there is any structural issues, then doing regenerative medicine. So we do quite a lot of people that if somebody already had ACL and they're seeing me, that means they're having issues, right? So when we get the MRI, we find out. So we correct that thing and we tell them, man, you need to find really good rehab. I'm glad I saw you guys now. So that somebody who knows what they're doing. So because the patient want to be active. It's not like you shut down everything. That's not an option. You want to heal it. You have an option to heal it. Then you go play active. Not only play, be active, right? That's part of his life. So we want to keep him there. And nowadays we have the options. We can keep him active, stay healthy till their last days.
Also, when patients or clients, they walk to us, they have a certain goals in their mind. Let's say for a 70-year-old granny, it can be just a goal of let me have a walk in the garden with my grandchild can be as a goal. Or an athlete who have probably win Olympic or something. So how do we take calls there when is there any difference that we have to keep in mind there when we are choosing what kind of regenerative medicines to be used based on the goals?
But again, it does not depend on the age or the condition. Say like the granny, for example, unable to walk. She's not asking to run. She's just like, I want to walk, but I cannot walk. And the arthritis is what bothering her. We can help her get to the point where she walks, she enjoys life, keeps her weight down, mental sanity. So her lifestyle can be improved. For her, that's a success. But for an athlete, he needs to be 100%. That means athlete is not going to wait till it's too far gone. They're going to come to us earlier. So it does not matter the age part, and also even the treatment part also, what you're trying to achieve. So an old person wants to walk, maintain their life, not to have pain, they're happy with that thing. And that can be achieved. So it's not only for athletes, It's for middle-aged, active people that want to stay active, even old people that have degeneration, and they want to keep moving. So the goal is, if we keep them moving, if we keep these healthy, they're fighting all other diseases. So the aging problem, the related diseases, metabolic diseases, can be all be prevented if somebody is active.
Yes.
And you're not going to get active at age 80
Yeah.
if you're not active at age 50, 60. You know,
Yes.
you say like, oh, I can be active. No, you start doing now, and then you can maintain that lifestyle.
I think to
So-
keep them going is something which we are really requiring at that
exactly.
age.
Yeah.
I think difference in approach is going to come in our way
Yes.
more than the treatment, because how we are going to rehab and recondition a 70-year-old compared to a professional athlete post the same treatment is going to be different, right? So
The goals
Very
are
good,
same,
specific.
but their approaches are different. You know, somebody need to be at their high level, somebody need to be functional. Yeah.
I have one question with regards to the treatment specifically, and because there are the PRPs and the other treatments about stem cells that you have mentioned, but there are some steroid-based treatment as well, and sometimes the reaction to the both becomes kind of it becomes united, and it is like a negative towards regeneration treatment
Yes.
itself.
Yes.
The thinking generally is in the long term it is going to weaken the tissue. So can you shed some light on that and tell the difference between the two?
Sure. So I would say 20 years ago, we were doing steroids because being sports medicine, all athletes were injecting steroids, putting them on the field, making them work because we didn't know anything. We had no regenerative medicine at that time. You know, the last 18, 20 years that we've been doing it, then we realized like, okay, we have a good alternative. And most of the steroid injections that we have done ended up in some kind of long-term issues.
Right.
For example, if I injected into the tendon or rotator cuff, we have seen higher rate of tears because of the tissue degradation right there. So now is not the time to do those because now we're in a generation where your body has all the things. Why do you want to put something that's detrimental to your body for 2 weeks of relief? So it is literally in our sports world, I would say it's almost disappeared, but it still happens. It still happens. Some people give steroids. So we recommend completely against it because it's not like, you can't, get out of the treatment because, as I said, like your body can treat it. So we just are able to do those things. So that's, I would say, was the greatest thing at one time. Now the biggest villain now. So we don't do that thing at all.
Yeah. Nice.
Correct. Also, I just want to ask a few questions there. What comes to your mind when a person with a PRP comes to a coach, strength and conditioning coach? Are there any specific do's and don'ts that strictly have to be followed for a certain period of time, or also is there any technicalities which we can discuss further about, like?
So first few things that should come in front of a strength and conditioning coach's mind is what injury was it originally, and what was the mechanism of an injury, whether it was an acute injury or a chronic injury or acute or chronic injury, because that gives us an idea about what are the questions that we should ask to a physiotherapist and a doctor, and then it gives us an information about how to go ahead with the starting point of our training programs, right? Because for example, like doctor said, if it's an acute injury, then the healing time is longer, and then we also have to take a more gradual approach towards building that athlete or a client up, as opposed to that if it's a chronic injury, then we can think about getting the athlete back much earlier, but then we need to focus more on the root causes which has resulted in that chronic injury, so that we can target that. So those are the few different things that we look at. But we also have to be mindful about early loading, because even though it is important to avoid detraining, we have to understand that we shouldn't aggravate a healing tissue, right? So we have to be really mindful about our selection of exercises. So for example, if there is a knee issue and the treatment has been done on a knee, then we have to ensure that we are avoiding a lot of shear forces, or compressive forces too early, because some of the exercises that can be termed into non-impact conditioning but can still have some level of compressive and shear forces on the joint. So we have to be really mindful about that.
Yeah, so I feel there when it comes to a protocol that we usually, throw light on, like let's start with a basic physio, but again, a progressive loading. And then once probably like after a 5 to 6 weeks, taking a call there and then, actually starting the strength and conditioning with them.
So I think it should be a match between a timeline and also the objective data gathering that we are doing, because some clients can respond early, and it all depends on the nature of an injury and the pre-injury fitness levels and training age, right? So it has to be a match between set timelines but also the objective outcomes that we are getting from our assessments, and that's where assessments become extremely important for us.
Okay, is there any certain timeline which is like has to be followed for impact training? Like I'm just asking out of
So
curiosity.
post procedures,
Yes.
you're
Yes,
asking,
yes.
yeah. So post procedure, obviously the biologics have a timeline.
Yes.
So when you do stem cells or platelets,
Yeah.
so we usually compare with a surgical correction. Say like somebody gets surgery for a meniscectomy, somebody gets stem cells for the meniscus. Typical recovery and time back to the sport is literally half compared to surgery.
That's great. Yeah.
If somebody has an ACL surgery, 8 months to 1 year, and our people go back to sports within 4 to 5 months, because we're not cutting anywhere. There is no cutting involved. When there is no cutting involved, there is no downtime of healing the tissues. So everything is like intervention with the needle based. So it's an outpatient procedure. So you're not disturbing the architecture. You're actually enhancing the architecture. So what happens is that's why people are able to walk same day, exercise within 5 days compared to a surgical thing. So, but loading, as you said, like, to optimal levels of the athletic part of it, we don't release anybody within 2 month period of time. But people are walking, people are exercising, people are doing all the basic stuff almost immediately.
Yeah.
So to answer your question, the timeline to be a peak performance, it's got to be beyond 2 months, within 4 months, basing on the patient's response rates as well. We never push them in the first month or two, because you got to give enough time to heal the tissue as well. Yeah.
Correct. And there where I think the assessments come into picture when we do a tech assessments, like, understanding how much is the strength, how much are the ratios that you have in the strength parameters, where then actually we can take a better call on when to start impact training and all of that.
Yeah. Because as you said, like everybody comes with different conditioning levels. Once you recognize it, there's a lot of correction to be made.
Yeah, absolutely.
You focus on the basic fundamentals again.
Yeah.
Even though, like, somebody is fit, but post-injury, we got to make sure that does not happen. So you may have to rewire that process. So it's not like the same exercise he was doing before, right? You will change him. So whenever you change and modify to get that response rates, it's going to be a while, but still significantly shorter compared to any surgery as well.
Yes. So just want to know your perspective when it comes to return to sport. How much do you feel this regenerative therapy can actually, be at a very, helping them out for return to sport? What is your take on this, or how does that?
No, I think it is really helpful, and it is actually revolutionized the return to performance and return to play, because you need to understand that when we're talking about athletes, what is always on their mind is their short career span, right? So they are always thinking about how quickly they can get back to their sports, right? And now if you have to take that aspect, mental aspect, and apply it with general population as well, ultimately everyone wants to be back to their normal
As
life
quick as
early
possible.
right? So in that sense, the regenerative medicine is extremely helpful for both athletic as well as the general population. However, from the strength and conditioning perspective, we need to be more mindful about the fact that our fundamentals don't change. Okay, they change in terms of the approach and timelines, because the regenerative therapy is helping us push the athlete uh, or progress the athlete more quickly, but our fundamentals should remain the same in terms of we understand the injury history, we understand the mechanics, and we start with the starting point should be what that athlete or client needs at that time. So for example, so a 70-year-old grandmother who has never trained in her life, has got a PRP in her knee, should not be starting with goblet squats as such, right? She should be starting with first understanding how to move correctly without pain. As opposed to that, a professional football player with a similar problem can start at a different starting point and gradually progress from there. So this is how we would look at it.
Great, great. So at Stance Health, we basically follow a very simple 3-step process to understand whether a client or a patient is actually, a potential candidate for a regenerative therapy. So initially, we start with a very detailed assessment, understanding their subjective data out of it, the objective data, the physical examination that we usually do, and then the tech-based assessments have to be done to understand the extent of injury and the chronicity, whether it is an acute case or a chronic case, which actually helps us to guide them whether to pursue the regenerative therapy as such and to take a better call. Then comes the step 2, where actually a client or a patient goes through a 4 to 6 week of physiotherapy protocol plus the lifestyle modification changes, so that in long run we get better outcomes out of that regenerative therapy. And this actually helps us, reducing pain and optimize the healing process in general as a whole. We keep monitoring their progress in terms of stability, strength, mobility, functional. And in that case, if they are showing us a good improvement, we continue the rehab and take them further for the process. But sometimes the rehab actually doesn't work out that well, and in that case we have to take a call that we have to start referring them to a sports med doctor for further outcomes or further decision making process as such as regenerative medicine or any of that sort. So in this way it helps the patient to get a right treatment on a right time, which I feel is really important.